Okay, we're going to talk about central venous access devices. We are starting on page 309 in your book. All right, guys, so central venous access devices are catheters that are actually placed in large blood vessels, such as the subclavian vein or the jugular. These are placed for people who require frequent or special access to the vascular system. So someone, for instance, who needs to get a lot of blood transfusions, someone who is getting chemotherapy, someone who's had so many needle sticks that their peripheral veins are no longer useful, are just a few reasons people might have central venous access devices. There are three main types that we're going to talk about, and those are centrally inserted catheters or central lines, peripherally inserted central catheters or PICC lines, and implanted ports. We've talked about most of the things on this slide, but I'm going to circle this word vesicant. You guys need to understand what a vesicant is. A vesicant is a solution or a drug that, when given, if it is allowed to leak into the tissue, it will kill the tissue. So that's a vesicant. So for instance, many chemotherapy agents are what we consider vesicants. And so it's truly not safe to give them through peripheral lines, because if they would leak into the tissue around the peripheral catheter, it could cause tissue necrosis. And so that's what a vesicant is. Okay, this just lists some of the advantages and disadvantages, and these are things that you guys need to monitor for. Obviously, advantages, we have immediate access. The patient's not going to be stuck as much, and the reason they're not going to be stuck as much too is because the majority of central venous access devices you can draw blood samples from. And so it requires an order, a physician's order. But let's say, it's morning, your patient has a PICC line, they need a CBC, a set of lights. Then with a physician's order, you can actually draw those out of the patient's PICC line. And this saves the patient a stick. We talked about vesicants. Well, if vesicants are allowed to infiltrate into the tissue, this is called extravasation. So extravasation is when vesicants leak into the tissue. Disadvantages, your patient is at risk for infection, so you want to monitor them closely for signs of local and systemic infections, and it is an invasive procedure. The main point on this slide is some catheters are considered non-tunneled and others are considered tunneled. So we're going to talk about non-tunneled versus tunneled as we go through these slides. Okay, this is an example of what we call a tunneled catheter. This picture is also in your book on page 310. What I want you to realize is, you can see right here, I'm circling the exit site. So all of this right here is actually under the patient's skin. You do not see it. So that's why it's considered a tunneled catheter. So much of the catheter is actually under the skin, and then it actually, in this picture, enters the subclavian vein right here, and then it'll rest just outside this, just in the superior vena cava, outside the right atrium. So you see just a small portion of the catheter, and an example of this particular type of catheter is either what we call a Groshon catheter or a Hickman catheter. So Groshon and Hickmans are examples of tunneled catheters. The advantages to having a tunneled catheter is there is a decreased incidence of infection for people who have tunneled catheters, and tunneled catheters can also stay in longer. This is a picture of a non-tunneled catheter, so a non-tunneled catheter, and as you can see, the catheter itself immediately enters into the vein, so no portion of it is tunneled under the skin, but it too will rest in the superior vena cava just outside the right atrium. So non-tunneled catheters have a higher incident of infection, and they cannot stay in as long, and typically only 7 to 10 days. So a non-tunnel catheter, a good example is what we call a central line. So increased risk for infection, can only stay in for 7 to 10 days. One thing I do want to say is anytime someone has either a tunneled or non-tunneled catheter placed, that patient immediately needs to go for a chest x-ray after the procedure to make sure that the catheter is in the correct place. If you're looking in your book on page 310, there is a picture of what we call a PICC line, a peripherally inserted central catheter. It is actually inserted in the vein in the arm, usually just above or right at the antecubital fossa. It can be single or multi-lumen, and it is considered a non-tunneled catheter because it directly enters the vein and is not tunneled under the skin. It's very useful for someone who has prolonged needs, can stay in if properly taken care of, up to 6 months. Just remember the side that this is on. You cannot use that arm for blood pressure or blood draws. These patients a lot of times can have this actually placed at the bedside by a nurse who's been properly trained, or sometimes they will go down to interventional radiology to have a PICC line placed. These are just some of the advantages and disadvantages or complications of PICC lines. They have lower infection rates. They're not as expensive as tunneled catheters because tunneled catheters are actually surgical procedures. If these are not flushed properly, then they can become occluded, and you can still have a phlebitis in a PICC line. And so we just have to make sure, as their nursing care includes flushes according to hospital policy. But the good thing is these can be placed, patients can be taught how to manage PICC lines, and patients can go home with these. This is just the picture of the PICC line that's in your book. Okay, so we're going to move on to the last type of device, and that's called an implanted infusion port. An implanted infusion port. Just going back a couple minutes, on page 310, there's an excellent chart that outlines why people might need central catheters. And then on page 311, there is a table that compares the different types of devices that we've talked about that you guys can refer to. But an implanted infusion device is actually a device that's the patient has to either go down to interventional radiology or to the OR. You actually take a port. The physician will make an incision typically under one of the collarbones, and the incision then the doctor will insert the port into a subcutaneous pocket of tissue, and then on the back side of that feed the actual catheter itself into a great vein, usually the subclavian, and then it to rest in the superior vena cava outside the right atrium. They can be single or double lumens. It is a device that can stay in for years if taken care of properly. And the other thing that sets the implanted infusion ports apart from central lines, tunneled and non-tunneled catheters, is that it's not visible. Once the scar heals, the patient does not have any signs that they actually have a device in place, and they have no restrictions. So often infusion ports are a great option for anyone who is active, would like to be able to go ahead and swim, and not have a visible catheter. So infusion ports typically are used for people who have some type of chronic need. Maybe they have, for instance, aplastic anemia and they need chronic red blood cell transfusions, or maybe they're on chemotherapy.